and hello, council members. So glad to get a chance to speak with you. If I can be a little bit personal for a second, I'm an immigrant to the U.S. I came to the U.S. when I was 8 years old, from Colombia in South America, and pretty much my whole life, all I can remember is wanting to be a physician and provide reproductive health care. Eventually had the opportunity to apply for the fellowship in family planning here at Columbia, which was appealing to me because it's Columbia, because I would be working with Carolyn Westhoff, and also because being an immigrant, I had always been drawn to taking care of patients from other nationalities, and in particular Spanish-speaking patients, and I got to do that here, and came here 20 years ago this year, and am still here. So clearly, a lot of the things that I came looking for came to fruition, but also many more things. And then over the last 20 years, I've gotten to work with the amazing people in our division, including Cepin, whom you know and you'll hear from in a few minutes, and also Dr. Westhoff, but also the department, including Mary, obviously, and everyone else in the department. I've also known Russ since I feel like he was a little baby. And so it's great to be in this community in general, but especially today. Unfortunately, we're talking about a difficult topic, but hopefully we'll show you all of the work that we do and all of our goals for ensuring that the impact after Dobbs for us is minimal, and that we can do our job to do what we need to do to ensure care for folks and to ensure that we're educating the next generation of clinicians. So I'm going to provide an overview of what the abortion landscape has been over the last 50 years. If we could advance a couple of slides, please. There we go. So on the left side here, you'll see what the number of abortions have looked like in the United States since abortion was made legal with Roe versus Wade in 1973. And what we know is that initially there was quite an increase in the number of abortions. Of course, we aren't seeing what was happening pre-1973, but we know that it wasn't that there were no abortions. They just were not safe and not legal and not really being counted in an official way. The numbers peaked in the 80s, probably at over 1.5 million abortions per year in the US. And then you can see this nice steady decline that has been going on over the last 20, 30 years. And many, we can attribute this decline to many things. It's probably quite multifactorial, but certainly education, sex education, the availability and increased availability of contraceptives, and especially very effective contraceptives. At the very end there, you can see that there's a tiny little blip that maybe it looked like numbers were going back up in the last few years. Again, probably multifactorial, but the thought was that we were starting to see some of the effects of some of the restrictions that were being placed on abortion in some states. And then if we look at the right-sided graph, we can see what proportion of the abortions that happen in the first trimester are actually not procedures, but completed via medications. And again, only started to count this in the year 2000 because that is when medication abortion became available in the United States. And I'll say, actually, our division, Dr. Westhoff, was involved in some of the early clinical trials that allowed for medication abortion to be proven to be safe and effective and to be available in the United States. And the proportion of women who use medication abortion early in their pregnancies to terminate a pregnancy has been increasing over the decades. And in 2020 actually became the majority of the way that most women in the United States who choose to have an abortion have an abortion. And then you may have heard that in the last couple of weeks, we had a change in the labeling related to one of the medication abortion medications called mifepristone. There have always been some pretty onerous, non-medically based restrictions on how the medication can be dispensed, who can prescribe it, who can use it. And we have fought for decades, literally trying to show that those restrictions were completely unnecessary. And finally, the FDA lifted some of those restrictions. And that will mean that if a pharmacy chooses to, they could actually stock this medication in the pharmacy. Until now, it's only been available in certain physician offices. It will still be available. It will need a clinician's prescription, but may be more accessible. And in particular, in states where abortion access is already limited. So that's a little silver lining in what's been a difficult year in the world of reproductive health for us. Next slide, please. There are many slides or pictures that you've probably seen like this, showing the United States and showing the states that unfortunately enacted many stronger abortion restrictions when the Dobbs decision came out in June, which essentially reversed the law that had been in place for Roe versus Wade. And of course, our larger organization that oversees the family planning clinicians in the United States wanted to study this and understand better what was happening. And so they already started counting the number of abortions all of us were performing before the Dobbs decision was released, and then have been continuing to count afterwards. And we at Columbia are also contributing numbers to this, this data collection. And overall, what we've seen is that in the months following the Dobbs decision, there have been about 5,000 fewer abortions per month across the United States. And unfortunately, that number has not been, the decrease has not, there's not been an equal increase in states that have fewer restrictions, but there definitely has been an increase in states, in particular states that are bordering the states in the South and the Southeast, which have the most restrictions. Even before the Dobbs decision formally came out, we had some predictions that said there would be an increase in volume in New York State. And now we know from this data that's been counted over the months of last year, we see that there has been an increase in the number of abortion patients that have been cared for in New York State. Overall, about a 12% increase, which is about 990 patients. Of course, New York State is a giant state, and there are many parts of New York State that are closer to some of these states with bigger restrictions. And so we've seen a very small increase in these patients here at Columbia within our family planning division. And we know that abortion restrictions in general disproportionately affect people of color and people with limited resources. And I think our goals are to ensure that we can try to balance that out a little bit, that we can make sure that we're not adding any additional obstacles and can help patients overcome any barriers so that they can get the care that they want. And I recognize that we're in a really privileged position here in New York State and New York City and at Columbia. And I think with that position comes a very big responsibility. And I think that we have to make sure that we can care for every patient that we can. And very importantly, that we can train the next generations of both medical students, residents, fellows. We have nursing students who spend time with us learning about abortion care, nurse practitioners. So really making sure that all of them get as good training as they can so that they can go forth and share that knowledge and provide excellent care. Next slide, please. So you already know me a little bit, and Anna Cepin, who will be talking in a few minutes. And I just wanted to show some of our other staff. Don't worry, I'm not going to talk about everyone, but I did want to highlight, obviously, Dr. Carolyn Westhoff, whom is familiar to all of you. She holds the Sarah Billinghurst Solomon Endowment. She birthed our division, our fellowship, our research machine, and has been a wonderful mentor over all of these years. We have, as Mary acknowledged, we have recruited a number of new clinicians and researchers to join us this year. Carolyn has connections to Planned Parenthood, as does Anna Cepin, as does Dr. Cohn, who's the picture on the top row on the right-hand side. Both Carolyn and Dr. Cohn have a connection to the Mailman School of Public Health. Dr. Cohn is our newest research director, and she is going to be teaching classes at the Mailman School of Public Health, is helping our fellows with resident medical students with research projects, our fellows with research projects and our medical students with research projects. And then on the bottom row, these are our amazing fellows who are the next generation of abortion providers. And I just wanted to highlight two of them for some particular reasons. In the lower left-hand corner is Dr. Gopika Krishna, who is going to be graduating this June, and she is considering perhaps spending a year with ACOG, the American College of Obstetricians and Gynecologists in DC, working on advocacy for family planning and abortion care in the US. And she will also likely be working in North Carolina, providing abortion care. North Carolina is one of those states that's next to many states with restrictions, and actually has been the state that has seen the largest increase in number of abortions since the Dobbs decision was handed down. 37% increase in the number of abortions they're doing in that state. So they need all of the help that they can get. And then lower right-hand corner is Dr. Lana Wynn, who came to us from Florida. And so will likely return to Florida after her fellowship. And she would then be our fifth fellow who would have gone to Florida after a fellowship here. Florida does have more restrictive abortion care, but also is in great need of amazing clinicians. Next slide, please. We offer patient-centered, confidential, bilingual, pro-choice, trauma-informed care through our division. And we always keep in mind that we have to have a reproductive health and justice lens when we're providing this care. And this lists the different areas where we provide care. And I know that we are limited in time, so I'm not going to spend a lot of time here, but just wanted to show that we provide care kind of across the reproductive health continuum. Next slide, please. And we are located at the 21 Audubon Avenue practice here in Washington Heights, and Dr. Cepin is going to talk more about that practice and the amazing work that they're doing. We're also, our faculty practice is at Columbus Circle in Midtown. We've had a faculty practice since 1997, and we're really proud that we see patients there regardless of what their insurance provider may be. We also have a complex contraception consultation where we work with clinicians from other departments for their patients who have complex medical conditions to ensure that they have the best contraceptive options available to them. And then we're also in the hospitals working in the operating rooms. Next slide. Specifically, since Dobbs, we can actually jump to the bottom of this slide. We have been, I'd say, lucky on some level that we have seen minimal increase in volume from states with anti-abortion laws. I hope largely this is because they are going to clinicians that are hopefully a little closer to their state than traveling to New York. However, what you'll notice from the states where we are getting patients, it's likely either it's likely because it's states where we probably have a lot of direct connections. And I don't mean necessarily clinical connections, but just I think a lot of people have connections with Texas, and a lot of people in New York have connections with Florida. But you can see that those are the two states where we have been seeing the most increase in volume from people from out of state. And we're really proud that the care that we provide has always been very good. Our safety record is better than the national rates that you see for complications for abortion, which is at baseline a very safe procedure that is even safer than pregnancy and childbirth. We are members of the National Abortion Federation, a group that oversees abortion clinicians throughout the United States and Canada, and actually South America as well, and provides us with education and with security assessments and trainings and resources, and very importantly, alerts so that we are aware if there are any things that we need to be aware of. And we're lucky also that we do not have any concerns about security or protesters, but we definitely take security very seriously, and we have precautions in place. Next slide. Please don't be scared by the volume of words on this slide, because I'm only going to focus on the lower left-hand corner, which is education. As I mentioned before, I think our focus, especially in a post-Dobbs landscape, is to focus on continuing to provide amazing care, but also to ensure that we train the next generation of clinicians. And obviously, we train all of the different levels of learners that I mentioned, but in particular, we have a fellowship program that's been present since 1997. We have graduated 29 fellows thus far. And as I mentioned, some have gone to Florida, some have gone to Texas. So we've definitely had some of our fellows now be in states where the plan wasn't that they were going to have restrictions, but that they now have restrictions, and they are navigating that landscape amazingly. And also many of them are in academic institutions and continuing to educate the next generation of clinicians in those states. Our subspecialty, after a number of decades, achieved accreditation 2 years ago. And so and our clinicians actually all became board certified in complex family planning last year. So very proud of them for that. Our fellowship historically was funded by a foundation, but with the transition to ACGME accreditation, that funding is no longer in place. Next slide, please. Again, this is going to be another busy slide, but I'm just going to be focusing on the lower left-hand corner. So again, our big goals for this year, in addition to ongoing clinical services, are to continue with our family planning fellowship. And then we also recognize that there are states where all of a sudden learners, medical students, residents are faced with a lack of access to clinical training in abortion care. And so we are actively working with them to allow them to come and spend time with us. And in particular, Ohio State University is in talks with us to do a resident exchange. Our residents can learn from things that are done differently in the Midwest, and their residents can come and expand their knowledge. Thankfully, Ohio's rules right now are kind of enjoined, but the thought is that's going to go away quickly. Next slide, please. Thank you, everyone.
Thanks very much, Paul. And without further ado, you've all met Anna before in the last Women's Healthcare Council. So I'm going to pass Anna on and have her share with you the impact on the community. Thank you, Anna.
Thank you, Mary, for the introduction, and thank you to the council for having me again. So I'd like to pivot now to discussing where our local community stands as it relates to abortion access and some of the responses to the decision. And so in this first slide, you'll see our family planning practice, which is a site that I talked about the first time I met with you. It's actually where I started my career here at Columbia. I worked there one summer as a teenager under Carolyn Westhoff, and am now the medical director of that practice. It's a site that's been in a program that's been in place for over 40 years. And its inception is a very interesting story. It was started by Dr. Rosenfield, who is an OBGYN, who was the dean of the School of Public Health. And he'd done a lot of work in global maternal and child health outcomes, and really understood the importance of access and how there was inequity in access. And so he had the idea to start this program. And at the same time, there was a federal legislation that was created to start the Title X program. And so the Title X program is a federal program that provides, that helps provide funding for providers to provide sexually and reproductive health care to women and men who are uninsured and underinsured. And so because of this funding, we are really able to provide robust services to the women of our community, and we've been doing that for many years. We provide a broad range of clinical care, all contraceptive options, GYN care, but one important thing as it relates to our discussion today is that we do pregnancy testing and options counseling. And if patients have decided to not continue their pregnancy, or if they've had a miscarriage, we can refer them to abortion services. Something that is unique to New York and also to this site is that in New York, unique to New York and other states, not all the states, pregnancy is usually a qualifying criteria for Medicaid coverage. And so women are able to obtain insurance for these services. So it's really great that we're able to provide that to our patients. And then other things that we do here is community outreach and engagement. Certainly education is really important. Like Paula mentioned, we are training the next generations of providers, and a lot of the seminal research on contraception has taken place there. It's a very busy site. We have over 15,000 visits a year. Next slide. And so now we have another opportunity to leverage public health financing for expansion of services. In response to Dobbs, Governor Hochul announced funding to expand abortion access throughout New York State. Our family planning practice was one of the sites that was selected for this program. And so the program is providing $25 million in funding to be distributed amongst 50 programs, and it's for funding for this calendar year. These are pictures from the ceremony where she announced the recipients of the funds, and that's me next to the governor. So she's been very supportive of abortion services and access in New York State. So we're very lucky to have her as our governor. Next slide. The project that was funded and that we are working on is the creation of telehealth medication abortion. So we're currently working to implement this program and should be able to start seeing patients soon. This is a way for us to be able to meet patients where they are and remove barriers to care. With this model, patients can self-schedule appointments for medication abortion. Then, and they do this via the portal, or they can call, but can certainly do this virtually. Then they have a video visit where if they meet criteria for medication abortion, they can then move on to the next step. They would then come in person to pick up their medication along with a heating pad and other comfort items, go home to do their medication abortion, and then have a follow-up video visit. So they can have essentially all this care virtually. So it's a really great increase of access for patients. They can also have in-person care if they prefer, or if they need immediate contraception, they can also be scheduled for that. We'll plan to have a patient navigator that's going to help with coordination and a nurse to help with distribution. And then certainly we'll want to evaluate this model to make sure that this is something that patients are satisfied with and see what we can do going forward. Next slide. And then lastly, I'd like to briefly comment on the community's response to the Dobbs decision. So activism and advocacy are hallmarks of this community, and it's really important that we as a department support and participate whenever we can. And so Paula mentioned how we work with ACOG and we work with advocacy and elected officials nationwide, but certainly important to do that on the local level as well. So a couple of things that have happened in the past year, I was happy to serve on this panel for sexual and reproductive health, the sexual and reproductive health community group panel that was in coordination with community-based organization partners about reproductive justice in response to abortion restrictions. And then there was also a very well-attended Uptown for Choice March, and I had an opportunity to speak at the rally. So again, I'd like to echo one of the things that Paula said, that one of the key takeaways is that although we are currently fortunate to live in a state like New York, we can never take this access for granted. And that we also do have this duty to advocate for women in other states, especially since we know that it is women who already have fewer resources who will be the most impacted by this decision. And then with that, I'll turn it over to Mary, who will introduce Russ.
Thanks very much, Anna. And Russ, I won't say very much about you except to say you were one of the most outstanding maternal fetal medicine doctors I've ever had the privilege of working with. I always ask you for advice. You do complicated procedures and you're the nicest person I could possibly imagine, and our patients love you. You represent us so very well. So thank you for being with us and talking about the complicated decisions you sometimes have to make. And I'm going to ask you to keep it as short as you can, maybe 5 minutes, because we're already a little bit late.
Absolutely. And thanks, Mary. That was really, that was very heartfelt and touching.
From the heart, as you know.
Thank you. And hi, council members. As you're seeing, the focus of this presentation today is really the incredible work that our family planning division does. I'd like to just add to it by describing some important collaborations we have between MFM and family planning, and also highlight some interesting clinical implications that Dobbs has had on certain aspects of MFM practice. So, for starters, a considerable portion of my time is spent evaluating and counseling patients with pregnancies complicated by severe fetal anomalies, genetic or other conditions. And I really couldn't imagine doing what I do without access to the care provided by experienced family planning subspecialists. Many patients come to our center because they want to continue with a pregnancy with this type of issue. Some don't. And it's so critical that we're able to support the full range of reproductive options available to these patients, and that includes access to abortion care. But our collaboration, our clinical collaboration, really extends to the hospital, inpatient care of patients who need abortion care because of immediate and severe threats to their own health. Prime examples are pre-viable rupture of membranes, intrauterine infection, severe hemorrhage. Abortion care in these cases can be and often is life-saving. Our family planning MFM collaboration extends also to the postpartum care of patients, especially some of our patients who are seeing us in the mother center with complex maternal medical conditions, who, future pregnancies might be very risky propositions. And so, helping them make decisions on what the best and most effective, birth control strategies for them might be is super important. And finally, there's an important educational component to our MFM family planning partnership. So CVS or chorionic villus sampling is a technique where we sample the early placenta in order to perform important genetic testing. And procedural success with CVS is really directly tied to experience. And so, at least at Columbia, CVS training involves having our fellows first perform CVS on patients with non-continuing pregnancies before they then go on to do them in continuing pregnancies. And this really only happens because we have supportive family planning colleagues, and not to mention just wonderful and willing patients who really care about the education of the next generation of MFM doctors. Shifting gears, we can go to the next slide. I promise it won't be too much longer. To the clinical implications of Dobbs on our MFM practice, I think it's important to just highlight that while it's true that abortion generally results in the end of a pregnancy, this isn't always the case. And there are infrequent instances in which patients may opt to terminate some, but not all fetuses within a multiple gestation. And these are procedures that MFMs perform. And so I won't go through all the details, but generally speaking, these options are usually risk-reducing decisions that patients make. So the first multifetal pregnancy reduction is really an upfront decision that a patient makes with her doctors to trade essentially the risk of a triplet or higher order multiple gestation for the more favorable risk profile of a twin or even singleton gestation. In other situations, patients may make the decision to selectively terminate one twin within a pair because that twin is a severe abnormality. And sometimes that abnormality can actually directly threaten the otherwise healthy co-twin. So these are super difficult decisions that patients often need to make, with their doctors to really terminate one twin in order to help the other. If we can go to the next slide. So it's especially true within complicated monochorionic gestations. So monochorionic twins are identical twins. They share a placenta and a placental circulation. And so this means that if something bad happens to one twin, for example, a twin passes away inside the uterus, it can directly harm the health or even cost the life of that co-twin. And so if one twin is very sick for really kind of whatever the reason, and the other appears healthy, there's a special procedure called RFA, where we can use a special probe and energy to selectively terminate one twin in order to safeguard the other. And so it's a technically challenging procedure that's only offered in a relatively small number of centers around the country, including our own. And since Dobbs, fewer centers are offering it. So if we can go to the next slide. So our therapy team at Columbia has now been offering RFA for probably close to 15 years, and we perform about 8 to 10 cases per year over these recent years. But the kind of interesting and unfortunate challenge post-Dobbs is that we're getting referrals from patients living in states with abortion bans who want this care but no longer have access. And so historically, we used to get, a handful of patients who came to us from far away for RFA, and we do the procedure, and then we'd have the patient return home, and we keep in close contact with them and their doctor. And that kind of partnership was so important to optimize outcomes, since complications can happen. But fast forwarding to 2023, this arrangement has become, problematic, because essentially a patient who now visits us from a state in which abortion is no longer legal and, has RFA, she's doing it within an ongoing gestation and then returning to a state in which abortion is illegal. And the problem for us to remain in close contact is even worse yet. It's that we could be accused of practicing medicine without a license in a state that's not kind of friendly to what's just happened. And so, this is just an enormous issue. And thankfully, our Columbia and NYPH legal teams have been really helpful in advising us and helping us navigate these issues. And I believe we're continuing to provide good care, but it's certainly a stressful experience. And so if we could just move on to the final slide. So this is now a few months old. It was this great article in the New York Times in which they just kind of mused an editorial that it's kind of these really post-Roe, post-Dobbs changes are forcing doctors to think like lawyers instead of just focusing on medical care. And that's true, but I think it goes further than that. I think there are a lot of implications on Dobbs that impact, so much of the care that we provide. I mean, patient and family issues, travel, expense, stress. There's no doubt that these restrictions are exacerbating healthcare disparities. The patients who are coming to see us for this care are patients who can afford to get on a plane and come here, or drive here and stay in a hotel, or whatever else they need. But as it relates to what I was just mentioning, there are huge communication barriers now. Simple things like calling a patient or the referring doctor are a challenge. Even writing on the report to that doctor, "Thank you for this referral." Well, has that doctor referred this patient to us? It gets just so involved. And so it really comes down to this challenge of, we could be accused of abetting the patient, but at the same time, if we just send her back without any plan, are we abandoning her? And so obviously there are safety concerns that result from all of this. So it's a new landscape that we're just trying to navigate each day. So I hope that I kept that reasonably brief. And thanks for your time.
You were awesome, Russ, as always. And I think you can see, those of you on this call, the wonderful physicians that we have navigating this new landscape. So we're absolutely thrilled to have them in our department as an enormous resource for the women that we are privileged to see. So we have a few minutes for questions. There's two ways to answer it. To ask them, just raise your hand in the reactions or just type them into the chat. I don't see anything so far, or just talk. We know all of you very, very well at this stage.
Dr. Dalton, we actually have two questions that were pre-submitted.
Of course.
So the first one is, what do you believe that the impact of Dobbs may be on IVF access eventually? And are there any states in which IVF access might be impacted soon?
Paula, do you want to take that?
Well, I certainly can take a stab at it. I mean, I'll start by saying that I'm not an IVF or reproductive endocrinology specialist. However, just like we collaborate closely with Mary and Russ and their division, we also share a lot of patients with the infertility folks at Columbia, or fertility folks. There's certainly what's been amazing and horrible about beyond the regular horribleness of the post-Dobbs decision has just been about sort of the effect that this has shown in other areas of care that we never thought about. And just as Russ said, some routine MFM procedures that no one ever thought would be questioned or would have any legal restrictions placed upon them are affected. Similarly, we're hearing that from our fertility colleagues. And so definitely there are concerns about whether some of these restrictions could affect what the work that our fertility colleagues can do, whether that is related to embryos and storage and transport across state lines, and similarly providing care of patients across state lines. So that is a concern. And what's been also sadly great about the post-Dobbs experience has been that our colleagues have all come together and we all realize we're in this fight together, and that again, even though we're in New York and we feel relatively safe as far as the direct effect of those laws on us, we know that that's not the case for everyone and for every field. And so we can work together to try to prevent as many of those restrictions as we can going forward.
Thanks. From my knowledge, I know it's a big anxiety, but it's not reality yet. And we can certainly send out something to the group when we discuss and confer with Zev Williams.
Great. I think Brittany also has a question, if you want to unmute.
Hi, thank you all so much for this, and especially for the doctors who spoke today for the amazing work. Dr. Miller, I think my question is to you as personally, candidly, someone who received a cerclage. I've wondered about women who receive cerclages perhaps later in the gestational time, and especially those that are traveling and then they return home, because I know, you're informed by your doctor that there's a window there that you're at a higher risk of miscarriage. And I'm worried about, but don't know if it's happening, that women are returning to other states may start to have a miscarriage. And does the removal of the cerclage become a question about, are you aiding and completing a miscarriage? I wasn't sure if you had any thoughts on it.
No, it's a great question. So, we have former fellows who are now in practice in both Texas and Florida, and these are the kind of concerns that on an everyday basis they're kind of dealing with, and oftentimes they're hypotheticals until they're not anymore. And so, absolutely, decisions like that. If you're taking out a cerclage that for medical reasons you believe needs to come out, but maybe the patient mom's life isn't in immediate jeopardy, are you actually, facilitating an abortion? And so I don't have answers, but I can tell you that the people kind of on the front line, so to speak, in these states are kind of grappling with these very issues. Oftentimes, instead of like we would normally do in medicine, reach out to a colleague, they're instead reaching out to their hospital lawyers because there's such tremendous challenges. So it's a great question.
Thanks.
And Brittany, if I may, I'd like to just add that you raise a kind of a larger question that has come up since post-Dobbs, which is just about pregnant people traveling to other states at baseline, whether or not they have a cerclage or any other health conditions. What if something happens and then they have to interact with the medical care there, and what ramifications does that have? And these are things I think never thought we were going to have to think about, fortunately.
We also had another pre-submitted question that says, how do you believe that the Dobbs decision will impact new physicians and choices of where to practice? Are doctors in OBGYN and maternal-fetal medicine choosing to leave their current positions because of the legal impact of their ability to provide services?
I can speak to that a little bit, having just participated in our most recent residency interview season. And so these are medical students who have decided to pursue a career in OBGYN and are now looking to match with the residency program. And it is certainly something that came up numerous times, that they're very aware of the fact that depending on where they go, they may not have any exposure to this care. And so that is certainly something that I think will factor into their decisions about where to train further. And I would say that the same is true for MFM and other specialties where you really want to make sure that you're trained in where the two intersect, like Russ just described. And so I think that it will definitely impact those decisions in terms of what's already happening, right? And so there are residents, there are medical students, there are fellows in restricted states right now, and it's very much a challenge. And so that's why Paula mentioned how we're thinking of hosting trainees from elsewhere, because this is really important. These are really important skills. And there are large numbers of trainees in the country that are not going to be exposed.
I don't think we've any real numbers on it yet, so that'll probably just happen as our professional organizations start to collect that information. But I haven't seen any real data on it yet, but it's an excellent question. So it's 5:03. We have no other submitted questions, but we're always happy to answer some more. And not seeing any or hearing any, I think we can call the meeting to a close. Thank you all for being part of our journey. I think most of you have been here since the beginning when we started talking about there's no health without mental health, and being able to announce the Bezos Family Foundation gift today is a wonderful culmination of our dreams at that time. And thank you all for believing in those. And Eden, thank you very much for, please convey our warmest thanks to the Bezos family. And we're so pleased and so excited about the potential. And our next step is the community, as you know. So we look forward to making that the same kind of reality over the next few years. So thank you all for your help, your confidence, and again, a very, very happy new year to all of you.